as the opener for our symposium. I would like to share with you some thoughts about the early detection of atrial fibrillation and rhythm control for the prevention of strokes and the interaction to stroke. I have no conflicts of interest to disclose with you. Hypertension and atrial fibrillation are in a very difficult and dangerous relation, as they promote each other in the way of a classical vicious circle. Millions of citizens and patients have undetected arterial hypertension, atrial fibrillation, and a significant number has both. There are clinical trial data that I will share with you later on that more than 70% of the patients that are diagnosed with atrial fibrillation included in trials also have hypertension. The vast majority of patients and people affected by hypertension and atrial fibrillation do not know that they are carrying these specific risks for severe complication. The most severe complication obviously is stroke, and they stay less symptomatic, asymptomatic at preclinical stages for a long period of time. And in this period of time, the citizens and the patients are at specific risks for developing the complications related to AF and to hypertension. And it does not matter whether or not the state of disease is asymptomatic, the risks got along with that as in symptomatic patients. This is taken from a beautiful recent review article in 2022 from Dominic Linz and colleagues explaining and exploring the interaction between atrial fibrillation and hypertension. And as I said before, both drive each other in the classical form of a vicious circle. Why it is so important? I already mentioned that because of the AF-related and hypertension-related complications, stroke, left ventricular dysfunction, heart failure, but also, and that has been under-recognized for many, many years, the effects of atrial fibrillation on mental dysfunction, which are serious, leading to cognitive decline, substantial cognitive decline, leading to a higher incidence of Alzheimer's disease, leading to depression, to impaired quality of life, and of course, to a substantial number of hospitalizations. And I will remind all of us that stroke is one of the most cost-intense medical states of disease for the societies, if you calculate the total costs related to that. Hypertension and the risk of stroke. There are very, very good data, and this has been taken from a recent publication in patients with hypertension and type 1 diabetes, that arterial hypertension is one of the key drivers for the risk of stroke. And there are more and more data showing that this is a nonlinear relation between the intensity of hypertension and the increased risk for stroke. So early detection of hypertension is really crucial. I will share with you a couple of ideas why this becomes even more evident looking to up-to-date clinical science and studies. Introduction of medical therapy for hypertension according to current guidelines is crucial, and we have strong recommendations for antihypertensive medications, for example, in the ESC guidelines. And appropriate therapy reduces the risk for cardiovascular complications and also of stroke if you can bring the patients on a medical basis into normotensive range. However, there's also evidence, and this further addresses the idea of early diagnostics of atrial fibrillation, that although you bring the patients on medications in normotensive range, their risk of stroke remains higher as compared to people that are normotensive and have the same profile. And this is important because it opens up the window for primordial and primary prevention of arterial hypertension. Once they have the hypertension, you need to diagnose it very, very early because there is evidence that with earlier introduction of treatment, the relation between remaining stroke risk and the occurrence of stroke when the patients are on medication may be beneficial for the patient. And we will see the same in the field of atrial fibrillation diagnostics. So this is my clear message to you for hypertension and for atrial fibrillation detection. Early detection makes sense. What are the data for early detection of atrial fibrillation with respect to outcome? They are also getting more and more stronger in the direction that rhythm-controlled therapy provides huge benefits for patients, not only on quality of life, but also for the reduction of atrial fibrillation-related complications. So we will look to the rationale. We will take a deep relook on the East AFNet-4 trial, which was one of the most important trials to open up the window for early treatment of atrial fibrillation. 88% of the patients included in East AFNet, 88%, almost 90% with an early diagnosis of atrial fibrillation had hypertension. That shows this clear linkage between these two states of disease. Early rhythm control strategy was one of the key parts of the East trial, and the introduction of therapy was just on average median 39 days following the first diagnosed atrial fibrillation. So early diagnosis and early treatment with rhythm control, and then strong state-of-the-art rhythm follow-up in these patients. What is the relation to the risk of stroke according to the East data? We will take a look to that in a minute from now, and then I would like to share with you real-world evidence data that go in the same direction, that early diagnostics and early treatment really make sense. Just a very brief reminder on the strategy of the East trial. It was a strategic trial, usual care, as compared to an early and comprehensive rhythm control strategy. It's important to note that most of the patients that were set on a rhythm control strategy were treated with antiarrhythmic drugs and not with catheter ablation. The electrophysiologists, they promote these data sometimes with a perspective that ablation may have the same benefits. It may be the case, but we need to show it. This was an antiarrhythmic drug trial where you see the usual antiarrhythmic drugs and the suspects. It's important to note that the patients that were randomized to the strategy of early rhythm control mainly stayed in that strategy, and the patients that were randomized to usual care, which was rate control in almost all patients, stayed on that therapy to more than 80% during the complete follow-up. The primary endpoint was a composite endpoint, including stroke, cardiovascular death, acute myocardial infarction, and worsening of heart failure hospitalization. This shows you on the left side the outcome of the primary endpoint, and the primary endpoint was significantly affected by the rhythm strategy as it was significantly lower in the rhythm control arm. On the right side, you see the incidence of different endpoints in both groups, and there were significant differences in 2 out of the 4 endpoints if you take a look to them in a separate manner. There was a reduction in cardiovascular death by 0.3%, and there was a reduction in stroke by rhythm control strategy. That means rhythm control is effective and reduces the risk of stroke and the development of stroke. I would like to share with you now data from real-world data sets that Greg Lipp and colleagues have put together that in essence call out the same message. The key question of this analysis was, if we map the East AFNet-4 patient population on a huge real-world evidence patient cohort, will we see the same effects that have been described in EAST, or will we see observations where the specific patient structure that you see in randomized controlled trials may have led to some of the observations made. So it's 5,300 patients in rhythm control and 17,000 patients in rate control, matched for the criteria for inclusion in the EAST trial. Here you see two of the main outcomes. Please focus on the left side. That's the endpoint of stroke, and you can see early diagnostics of atrial fibrillation, early treatment of atrial fibrillation reduces the incidence of stroke. This is an interesting analysis as it shows the time windows that we have years after diagnosis of atrial fibrillation and the effects that rhythm control has. And it's interesting to see that the effects of ischemic stroke may give us a wider window from the first diagnostics until the introduction of treatment as compared to the endpoint of hospitalization. This is my second last slide, and it again refers to the element of time interval between diagnosis of atrial fibrillation and introduction of rhythm control strategy. And as you can see in all the analysis, the 6 months window and the 1 year window for stroke seems to provide substantial benefits as compared to later treatment. Actually, in 5 or more years of the diagnosis of atrial fibrillation, rhythm control may not have beneficial effects in these patients. I would like to summarize: early detection, documentation of atrial fibrillation is crucial. Early rhythm control results in a significant reduction of stroke and cardiovascular death. This has been shown by the EAST trial and confirmed by real-world evidence data. These effects may be synergistic to antihypertensive therapy as recommended in current guidelines. Systematic screening for AF should be done in selected individuals with risk factors for atrial fibrillation, such as hypertension. Thank you very much for your attention.